Today I want to talk about the SI joint pain diagnosis and treatment. And so first of all, I need to disclose, unfortunately, no one paid me anything for this talk. I don't know why, but even though I will mention some of the instrument name and all that kind of things, but I want everyone to know that I'm not endorsing anything, and but just necessary that I may mention some company name. But I am not endorsing. No one pay me anything. Okay.
But you're available, right?
So first of all, even though I talk about SI joint, I need to mention about low back pain. Low back pain, all of us are spine surgeons here. We see a lot, okay? And it's a very common problem that we see in our clinic. And as a surgeon, we also operate on patients with lower back pain due to various reasons. And but from all this study here, show that actually, the cause of low back pain, the pain generators, can be multiple. If facet joint, we just saw one that have a facet degeneration, of course, disc degeneration, ligamentous injury, and all that, spondylolisthesis. And then it's complicated with a low back pain. Patient can actually have a hip pain and come to see us, and then we try to figure it out. Is it a hip problem? Is it a lower back problem? One thing is actually the SI joint can also present as lower back pain. Now, for physiatrist colleagues here, they are very familiar with SI joint pain because they see a lot in their practice too. But for surgeon, okay, and they probably not that common, And before I pick up doing some SI joint surgery, from my residency and my training, I never see one SI joint problem, never do a C1 surgery. So, even see one, do one, teach one, I can even do one and teach one and never see one. And I wonder how many of my colleagues here, surgeon colleagues, during their residency and actually have seen and done some SI joint fusion. So it's for surgeon, it's a very uncommon, but we must also now start to consider SI joint can be a pain generator when we work with a patient with lower back pain. The reason is from all the studies so far, it have shown various studies showing about 20 to 25% of lower back pain can cause by SI joint pain. Now, of course, some patients can have a hip joint, lower back degeneration, and SI joint pain all together to give the lower back pain. So the thing is, from all this, we as a surgeon, when we see a patient, we start to have to think about SI joint pain as the origin of lower back pain. Some basic anatomy. SI joint actually is a very large joint. The average surface area is 17.5 centimeters. It's a big joint. And the reason why it's so big is because it's for weight bearing, as we can imagine. And but because it's not a mobile joint. Okay, only about a couple of millimeters, especially during women doing vaginal delivery. The SI joint may open a little bit. Other than that, SI joint is not a mobile joint. So, but the anatomy of SI joint, if you look at that, in order to stabilize the SI joint, you need a lot of ligament to bind the joints together, and so the ligaments support is really important, and together with some more muscular stabilization. So it's mainly the ligament and the muscle that bind the SI joint together so that I can stand up right here, so I'm not falling apart. Okay, and also why SI joint can be the pain origin, because there's a very complex nerve innervation, S2, 3, 4, those tiny small nerve ending actually innervate into the SI joint, and that's why SI joint can be a pain generator. So what causes SI joint problem? A lot of times it's trauma. I see a lot of patients have a history of it fell from the tree or from the ladder and land on the butt. So-called land on the butt is right at the SI joint, okay? Or MVA, now motor vehicle accident actually can be quite common, especially now. Imagine that if I'm putting my my leg on the brake, okay, and then I get rear-ended, okay, so my whole body moves, but my leg is stabilized because I'm on the brake. So you can imagine that force will transmit it to the SI joint. Just move a little bit. You don't have to fracture anything, can cause SI joint pain down the road, okay? So atraumatic, there's a lot of other reasons, and actually they found out that SI joint is also adjacent joint. Now, for all the surgeon and the spine specialists know that, adjacent level fusion, adjacent level next to the fusion level, eventually can be a problem. Okay, adjacent level degeneration, we hear that all the time. SI joint actually is also adjacent level. If someone have a lumbar sacral fusion. So the potential causes, and trauma is still the most common, about 44%. Okay, and then there's a history of previous lumbar surgery. Depends on what study you look at. It can be about 20%. Okay, and repeated injury, and about 16%. When I see my patient, I try to ask what can be the cause. There's no good reasons to have an SI joint problem, so it's idiopathic. So adjacent segment disorder, and we talk about that all the time. It's a topic in spine surgery, and it's also a hip-spine relationship, But if you look at this patient with L3 to sacrum fusion, is really rigid. Okay, the lowest lumbar spine to the sacrum is very rigid, and you can imagine a lot of the force can transmit it to the bilateral SI joint. So there's some study to show that too, and I don't have a lot of time, so I just want to jump through it to this particular study to show that there's a significant percentage compared with the control group that SI joint can be a adjacent level and can be the origin of pain, especially for patients that have a previous lumbar sacral effusion. So this is a study by a couple of studies to show that all lower back pain, 22% can caused by the SI joint pain, as I mentioned earlier. But for those people who have lumbar sacral fusion, about 43%, okay, can have a SI joint pain. So a lot of time when we see the patient, including myself, I'm talking about myself in the past especially, the patient after my fusion a few years ago, have like a L4 to S1 fusion, and then was doing great, and then I'll come back to see me, I have more pain. Now in the past, I would say I look at CT scan, X-ray, picture looks good. And of course, I bring the patient, must be in your head, have secondary gain, there's no good reason you have pain because my work is so great, and the picture looks good. Okay, no pinch nerve. Okay, go home. And I send to physiatrists and let them play with it, there's nothing more that I can do. But now, for me to start to aware of SI joint can be the pain origin, especially after lumbar sacral fusion, I will start to work up some of my patients or patients from work rate by other surgeons come to see me. They have previous lumbar sacral fusion, and now complaining of pain, and I will work and see whether this patient actually have an SI joint pain. And if you look for it, you will find it. So SI joint often overlooked as the pain generator for lower back, especially for surgeons. As I said, we never get exposed to that during my residency, and now of course I'm an older generation, but I have a resident now at UCSD from the same program. You ever see a SI joint fusion? No. Okay, so have not changed it after so many, not that many decades, but maybe a couple of decades now. We overlook, we usually do not, lower back pain, we don't look for SI joint as a pain origin. And the spine surgeon, because he never see one, never get trained to look for it, and we cannot fix it, never see the surgery like this, so assume we cannot fix it, so assume this is not a problem. This is the current practice for SI joint, it's being overlooked. So about then, how to work up a SI joint pain, okay, the diagnosis, how to establish a diagnosis. Now, unlike all the lumbar problem, we see a lot of MRI, CT scan, with CT myelogram, all that. Imaging study, most of the time, is not helpful in making the diagnosis of SI joint. So SI joint surgery, the newer one, mini-invasive, is not that difficult. The difficult actually is in making the diagnosis of SI joint pain, okay? And to make a diagnosis, first thing first, okay, go back to basic, go back to medical school, what we learn in medical school, history and physical. Nowadays, a lot of time we jump, what's the MRI show, and then decide what we want to do. But in SI joint, we have to go back to the basic, get the history, do the physical examination, okay? So the patient presentation, usually, the pain is lower than L5. SI joint, we know where it's located. So it's not going to be, if a patient have a mid-back pain or above the pelvic girdle, the pain is there, most likely is not a SI joint pain. It's mainly at the pelvis and buttock. And the patient can also present it with some hip pain, groin pain, and patient have some, cannot sleep because they cannot lay on that side of the SI joint having a problem, okay? And so sitting can be painful, and I have enough experience when I walk into a room, if a patient sit with what I call, quote unquote, elevated butt sign, it will suggest to me that this may be SI joint. The patient avoid putting pressure on that side of the SI joint pain. So when they sit, they elevate a little bit and shift the weight to the other side that's not painful. So there's also some aggravating factors like motion, okay, direct pressures, okay, on the painful side, okay, and relieving factor is just the opposite. If you take the pressure off the SI joint, it's not as painful. So it's not that difficult to when you interview a patient to find out whether to suggest this may be SI joint problem. So SI joint pain, never midline, okay, it's either right side, left side, okay, always below L5, okay. Occasionally it can go to the groin and lateral find the hip, okay, and also there's usually the patient can tell you using one finger to point it hurts here, okay. So the pain can be very focused, have an epicenter. Now, so the problem is why it's so difficult to make a diagnosis just based on a physical and examination, because discogenic pain, okay, radiculopathy can present with pain also like a SI joint or facet joint pain, okay. Now SI joint pain, if you look at all this picture, actually they all look the same. It overlap. The patient can have a hip problem but look like SI joint problem, okay. Now, if the SI joint is a big joint, if the SI joint is from the front, the patient can also have some groin pain, okay? So we make us think about, if you never think about SI joint, you think about, well, would that be L2, L3 problem? So that, because of the overlapping of the pain referral patterns, that make the diagnosis challenging. So then after the history, you go to physical examination. Now, this is a Fontaine finger test. Actually, this Fontaine, Dr. Fontaine is lucky, that he, it's very simple. Use one finger, it hurts here. So he called it Fontaine finger test, okay? So usually the patient have that, and you press on that point, patient will jump, okay? So it's a typical presentation. And it's tender over that painful SI joint. And I've mentioned earlier, the patient try to avoid applying direct pressure on their SI joints, like when they sit or when they stand, they try to shift their weight towards the non-painful side. Now, so the physical examination, that's called the provocative test. Actually, you try to cause pain to the patients, okay? And so there's 5 different ways, how you can torture the patient to reproduce the pain. Now, usually we want 3 out of 5, out of this, especially the compression test and the 5 thrust tests are more diagnostic. If the patient is positive for this type of test, it's more suggestive the patient is truly having SI joint problem. So now, we get a positive history. Now we get a positive Fontaine finger test. You also press on that, the patient ouch and jumped, and now you start to torture the patient with some provocative test, and it's also positive. Now, history and physical highly suggest of that, but it's not diagnostic. So the next thing you should do is to refer the patient to have a SI joint diagnostic injection. Okay, so this is like the step actually by the IASP, and that is what they recommend is, physical examination, provocative test, and then you go for SI joint, which is nowadays still the gold standard to establish the diagnosis of SI joint pain. So now, it's not anyone can do it. You have to do it in the right way, okay? So, you inject basically some lidocaine, into the SI joint, and then within 20 to 30 minutes, the patient should say they are better if they are truly having SI joint pain. But what's mean by better? I will talk about that. But, another thing is to do this test, usually when I refer to, I want to make sure whoever do the injection know how to do it. Now, I don't do injection. I only know how to cut. So whoever do the injection, I have to talk to them, because you cannot inject too much volume. If you inject like 5 cc and all this extra fluid that spill out and lump up everything around it, it's not diagnostic. You can have a false positive for making an SI joint diagnosis. So the volume limit to about 1.5 ml only, okay? So with about 1.25 cc of local anesthetic agents. So what is meant by positive? Okay, the patient should get better, at least 75%. It's like a night and day. Wow, it's so much better. That is when I ask the patient, are you better? If they're telling me that, then I believe the patient truly benefits from the SI joint, or making a positive diagnosis. If the patient say, hey, I think so, maybe, no, that's not true. Those can be placebo, okay? So I want really significant night and day difference result from the SI joint injection. And during the patient feel better that period of time, they can do bending, lifting, twisting, put pressure on the SI joint, have no problem. That is what I'm looking for as a positive diagnosis for SI joint. And as I mentioned already, CT scan, MRI, most of the time just negative, unless the patient have a bad trauma, have fracture, and otherwise, they're not going to be helpful. They all look normal, okay? And maybe someone have an inflammation, a bone scan may help, but not a lot of patients with SI joint pain will have a positive bone scan either. So to make the diagnosis here now from history, physical examination, provocative test, and then you do the diagnostic injection and you still significantly better, then we go to treatment. Now, for me, usually I would like to have 2 injections, both positive, to convince me, okay? Because as I say, the surgery itself is easy, but to make a diagnosis is more difficult. So I want to make sure the second test, the patient will have the same type of result for me to comfortably think that this patient have an SI joint problem. So if you confirm this patient have an SI joint problem, then we treat the patient with SI joint. Of course, we treat it with most patients, they won't need surgery, okay? They with physical therapy, chiropractic manipulation, they get better, okay? And if still not getting better with this no non-invasive, then you can put the patient into a little bit more invasive, is still SI joint injection. But this time, instead of just local anesthetic agent, you also put in some steroid, cortisone, so the effect can last longer. I have patients that after the injection like that and get better for months, okay? So they don't need any surgery, they're better, okay? And if the pain come back, this type of patient can have radio frequency ablation to destroy the nerve ending so that they don't feel the pain. So eventually, if a patient fail all this conservative care, then you refer the surgeon to think about surgery. So physical therapy, some of you, especially the psychiatrists, know better than me, how to do that physical therapy. But the goal is to decrease the mobility. Probably is to tighten up the muscle around the SI joint to increase the stability, decrease the mobility. It's the motion. It's a non-mobile joint, but this micro motion of few millimeter with so much nerve ending is that can cause a lot of pain. So PT, as a first step, can be helpful to a lot of patients. Sometimes the physical therapy will also prescribe a SI belt to further stabilizing the SI joint, and that should provide a relief to the patients too. So if that failed, then you think our patient can have a SI joint injection, but this time it's for therapeutic instead of diagnostic, so you add some corticosteroid there. Okay, and if not helpful, then they can have a radio frequency ablation of the nerve endings. Now, in theory, that should help for the whole years. The nerve ending will regenerate, the pain will come back, but for whole years, actually, it's quite a good relief, right? I found out that if patients respond to a fake radio frequency ablation, at least for those patients that come to see me, of course I'm biased, that's why they end up in my office, it only helps for a few months and then come back. Okay, and they have repeated ablations. Eventually, whoever doing that, you go and see the surgeon. Okay, so then I want to talk about surgical treatment. Now, about sacroiliac joint fusion. Okay, the treatment, to eliminate the motion is by fusion. This is nothing new at all. Just to minimize the movement, so to eliminate the irritation to the nerve ending, and the short-term goal is to stabilize the SI joint immediately. The long-term goal, of course, you want bone fusion to occur. And a lot of times when I first about SI joint, because I never see one, do one, teach one, that kind of things when I was in residency, I thought it's something new when I get exposed to that. But I actually look at the literature myself. In 1926, it's already have SI joint fusion. At that time, of course, they do it open. 1926, none of us were born at that time. Okay, so this is not a new procedure for SI joint fusion. Okay, so but the thing is, you can imagine, like I tell you earlier, with the SI joint with a lot of ligament, muscle to hold them together, to do a fusion, you can imagine that you have to destroy all those structure to put bone graft in. So that's the reason why the result is not that great. Okay, the result for SI joint fusion is not that great, so most surgeons would not even do it. That's the reason why, at least in the surgical world, SI joint fusion disappear basically, except for trauma. Okay, but for degeneration, for other reasons, that's why we never see one during our residency or during my early practice. And a lot of my colleagues here never see one or do one. So now then, I follow the literature in 2001, which is not long ago, 14 years ago, they say there's a new procedure, new technique. Is really nothing new. It's still open. You still have to destroy all the ligament and muscle, to get to the SI joint, and then you put some bone graft, put some instrumentation. Now, 14 years ago, they call it a new procedure, but still the result is not good because it may not fuse. It's a very destructive procedure to lay bone graft on. So even though in 2001, someone published that, still, it's not a common procedure. Until more recently, they start to have minimally invasive type of SI joint fusion come out. Okay, now, as I say, I'm not endorsing any company, but I will show picture that what company I use, but I want to say that now more and more companies have the device for SI joint fusion. So it's really up to the surgeon, whatever device they want to use. So, and the one that I use actually is, you put rod in, all these devices, they're quite similar in theory, okay? And the approach are also very similar. So the device that I use is a triangular shape, so that, if you put a round shape, you can still rotate. But if you put in a triangular shape, you can no longer rotate. So you eliminate the motion immediately, especially when you put in 3 of those inside. Okay, so this is a model that actually has some 3 rods. I'm going to pass it around. Okay, so this is a picture of an API lateral. You can see the 3 rods going through from the ilium through to the sacrum. Okay, of course, the trick is we have to do it a lot under X-ray, a lot of X-ray. Okay, do not put it into the S1 foramen. Okay, you can see the foramen in the don't jam the rod into the foramen and give the patient ridiculous pain. So this is the only potential risk. Otherwise, quite a safe procedure. The only thing is, now this procedure is done from the side, from the hip here. So you do not have to open and destroy any of the ligament or muscle that binding the SI joint together. So you totally avoid that. You get from the hip, which when you go through that, it's a thick layer of fat. Okay, sometimes when I go in a patient, I look at the patient, I say, oh, I don't want to do it. With a hip that big, you can imagine that, the layer of fat you have to go through, and then you can start to see the fascia, and open the fascia is the muscle. You can do the blunt dissection through the muscle, then it's the bone, it's the ilium. So there's no really any ligament binding that you are destroying, and the muscle, you split it open. It's not like you have to cut through the muscle and destroy a lot of muscle. So this is, as I say, we rely on, for all, just like all minimally invasive procedure, we can't see much. we rely on X-ray to tell us where we are. So they have an inlet view to see the pelvic rim, and then you have the outlet view to look at the foramen inside the sacrum, so that you can avoid jamming the rod, the device into the foramen. So the inlet view, you see actually there's 3 rods lying together. The key thing is you don't want the rod end up past the rim, because there can be some retroperitoneal pelvic structure that you don't want to get into, like a uterus, ovary, some pelvic veins, that kind of, not to mention about bowel, that kind of good stuff. So you maintain all in bone. So outlet view is you can see how the rod, the 3 rod away is kind of avoiding the foramen, and then the lateral view all situated within the sacrum. So this is, you basically, you immediately decrease the motion of the SI joint once you put it in, okay? And the whole procedure takes 1 to 2 hours, half of the time for X-ray. The surgery itself actually is only about half an hour, but you have to position the patient, make sure you have a perfect inlet view, outlet view. So it takes longer time for the X-ray than the surgery itself. And the patient go home next day, okay? And the patient actually can have some weight bearing on that side, but I will ask the patient, don't do immediate full 100% weight bearing, but maybe just partial weight bearing on the affected side. And the pain, other than the pain from the cut, the SI joint pain, when I talk to a patient, is basically immediately better after the procedure. So, this is just some case, this is a patient postpartum, have multiple vaginal delivery, and this is the only history that I can find that can cause an SI joint problem. And the injection show more than 80% reduction in pain, and have been treated with all the other means, but the pain just keep on coming back. And then we do a SI joint fusion, and the result is great, and the patients return to full-time work within 12 weeks post-op. And I say the reduction in pain post-op, same as the 2 weeks after the injection. Is that 2 weeks the patient think that, wow, all pain go away? That is more than 80% relief. After surgery is that kind of result. This is another patient that actually is a trauma and have SI joint fusion on the right side by a surgeon in Detroit. At that time, I think in 2011, actually on the left side, I should say, they don't have this kind of fancy equipment, or the surgeon not using that. I think the screw, or you can see that it's like you can buy from Home Depot, okay, but still work, okay. They put in 3 screw, Home Depot-like screw that holding the SI joint, and still worked, actually get better. But then it's the other side giving her the problem. She's supposed to go back to the surgeon, but the surgeon retired. So that's how she ended up in me, and I put in something a lot more expensive than the Home Depot screw, and still work. And this patient is 61 years old, typical L3-S1 fusion, was doing great, and then later on developed pain, 2 years after the fusion, and then all the workup showed that it's a left side SI joint problem, and end up having the SI joint fusion, and after that the pain get better. So this is from the study to show that, as I say, if you can make the correct diagnosis, okay, the yield, I mean, the patient get better is really high. It's about 82%. Still, there's no 100% success surgery. We all know that. But, the key thing is to make the correct diagnosis. So the other 20% not getting better may have some other things going on. Okay, can maybe really depressed. If a patient really depressed, the pain perception is different, or patient on chronic pain, or that, the pain will never get better. But otherwise, the success rate for SI joint fusion on the right patients, appropriate patient, is very high. So it's evidence-based. Nowadays we talk about evidence-based. People challenge it is that now, because SI joint fusion, minimal invasive approach, is no longer that new. So in the past 5 years, there's a lot of publication coming up. Okay, so I just list a few. There's a lot more. If you guys have interest to look into that, to see whether SI joint fusion, minimal invasive approach, is the efficacy and safety actually is very favorable. Okay, so the conclusion here is now, especially for the surgeon, when we see a patient with low back pain, especially after our fusion come back a few years later, we also have to consider SI joint is a shift in the approach to making diagnosis for low back pain. And for an accurate and complete diagnosis, SI joint should be part of the low back pain patient evaluation. And so SI joint, even nowadays, is still underdiagnosed, okay? And the treatment goal for SI joint problem is to reduce the symptoms by decrease the mobility of the SI joint. Okay, I think time's up. When I saw you stand up, I suddenly freeze and stop. Okay, time's up.
Thank you, John. Very good.
Thank you.